with a CTPA.
Okay.
For her. So have a look at this. I'm not going to change the window.
Okay.
I'm going to leave it on this window, and then I will show you the long window later. Have a look at this window first. This tiny window.
Okay, so the increased density that was seen on chest X-ray corresponds to a kind of a mixed soft tissue, potentially cystic kind of density that
I'm going to show you the
qualitative process more because there's air bronchograms.
I'm going to show you the long window.
Okay.
Before you continue.
Okay, yeah.
Because that will add to your description.
Okay.
The upper lobes were normal.
Yeah. Okay.
So I'll go back to the soft tissue window.
Yeah.
Okay.
Okay.
Let's go back.
So within the area of abnormality, there are multiple kind of cystic or dilated, what I felt to be airways, so bronchiotactic airways potentially with fluid levels within them, and there's also a soft tissue component. I also was mindful that there was a vascular structure that was potentially draining into the systemic system, and I'm wondering whether this is a sequestration.
Let's follow it, okay? You're talking about this, isn't it?
Yeah.
This structure, okay. Let's follow it. Okay, so it's here.
Yeah. Okay, so I don't know whether that might represent is that an aneurysmal vessel? Or?
What about the caliber? Is it of a large caliber or? Not really, isn't it?
Not really, no. It was just the configuration of it. It might have just been the way it was scrolling through, as in it.
Yes. Sorry, this is live and it's a bit...
No, don't apologise. It's lovely. Thank you.
You're clunky. But anyway, if we follow this,
yeah.
So we're going to follow this vessel medially.
Yeah. Okay, yeah. So it's pacifying at the same time, in its arterial kind of enhancement.
Yeah.
And I'm following it immediately.
Okay.
Yeah. So
expect tortuous.
Yeah. But I imagine that it's going to get to the aorta, maybe.
Let's see. Okay, can you still see it?
Yeah.
Yeah. Yeah.
So it's still going. Okay, so it's coming off of the SMA.
The celiac, actually.
Celiac, apologies, yeah. Okay.
So you couldn't tell because you didn't know there was a celiac coming off above it.
Yeah.
This is the celiac trunk.
Yeah.
Yeah, so it's coming off the celiac trunk. So
I've got a lesion that has got systemic arterial blood supply opposed to pulmonary, which would be in keeping. And there was potentially I didn't properly look at it, and it is better on coronal sometimes to ascertain the communication with the airway. But I think this is consistent with sequestration.
Right. I'll show you a MIP image.
And I wasn't confident that I could see its own pleural. It didn't seem to be clearly encapsulated in its own pleura.
No.
So it's an extralobar sequestration. Intralobar, sorry, yeah.
The more common one, isn't it?
Yeah.
Okay, great. Look at that.
Oh, that's beautiful, yeah.
So it's arising from celiac trunk there, and supplying this area of lung. Well done. You suspected the pathology from the chest x-ray, which is brilliant, which shows that you are thinking in exam mode, which is good. Okay. So this lady had an infected intralobar sequestration, and the intralobar type accounts for 75% of all the sequestrations. The extralobar type accounts for the rest of the 25%, and they usually present in childhood with infections, recurrent infections. So with intralobar sequestration, the lung tissue does not have its own pleural covering. The recurrent infections produce these aberrant arterial vessels, which arise at some point from the aorta. Most commonly, the feeding vessel is from the thoracic aorta in 75%, but at times may arise from the abdominal aorta or its branches, intercostal arteries, or multiple arteries. There's a predilection towards the lower lobes, particularly the left lower lobe, and the treatment is surgical excision of this area of sequestered lung. The differential diagnosis includes congenital pulmonary airway malformations, formerly known as CCAMs, and you can have a hybrid lesion between the two. So you can have a hybrid lesion, sequestration, and CPAM. Can be quite difficult to distinguish at times. Neuroblastoma, especially if they present in a younger age group, in pediatrics. A bronchogenic cyst, but those would not have a separate arterial supply, as we saw in this case. Or bronchiectasis in an infected intralobar sequestration. Can present with sort of those cystic infected areas. Well done.
Thank you.
Okay. Let's move on to the next candidate now. So I have unmuted you, candidate 5.
Hi.
Hi. Are you ready?
Yeah.
For some more cardiothoracic? Okay.
Mm-hmm.
Great. So this is a 32-year-old male with shortness of breath who presented during COVID times with shortness of breath. So the question on the request was query COVID on his chest x-ray request. So let's bring up your imaging. So 32-year-old male, shortness of breath, query COVID.
I can see your presentation, but
Oh, sorry. Apologies for that. Okay, can you see it now?
Not yet, but probably I think it will come through. Yeah, now I can see it.
Great. Okay, whenever you're ready. Go for it.
So it's a frontal chest radiograph of a 32-year-old male patient with shortness of breath. I can see there are bilateral pulmonary infiltrates, likely in alveolar pattern, especially in the right mid zone and the lower zone where there's a confluent of infiltrating shadows. Apart from that, there's no pleural effusion. The bones, the trachea is central. I cannot see any lymph nodal or hilar enlargement, and the bones are fine. So, in summary, this chest X-ray is demonstrating bilateral pulmonary infiltrates, mainly in the right, predominantly in the right lungs, especially in the peripheral zone. Differential here, in the context of clinical history, this could well represent COVID, but then the patient will have to go by the history. If the patient is having clinical symptoms of COVID, then this can present COVID. Other differential in a perfectly normal patient of this age group could be any underlying vasculitic picture with this kind of pulmonary hemorrhage or consolidation. So I would write my report that COVID is likely if the patient has got a history or clinical symptoms of COVID.
It would correlate with PCR.
To confirm, I would go with the CT thorax.
Mm-hmm. So the swab came back negative. Does not definitively exclude COVID, as you know.
Yeah.
But we did a CT for this gentleman because his clinicians were getting quite worried about him and they wanted to see what's going on. So he had a CT and I wanted to focus on the mediastinum, and then I will change to lung window later and you can look at the lungs as well.
So
I'll show you the lung window. I'll show you the lung window. Okay, I'll scroll through once again. So you'll have a look at the lungs now. And then try and put everything together. What you saw in the mediastinum with what you're seeing now within the lungs.
yeah.
Okay.
There are bilateral predominantly perilymphatic nodular opacities with some confluent areas of consolidation or nodularity, bigger nodules. There's some adjacent tracheal bronchial dilatation as well. There's the mediastinal lymphadenopathy, especially in the paratracheal AP window and bilateral distribution as well. The appearance are quite suggestive of some, so these are perilymphatic distribution.
Mm-hmm.
Nodularity. Sarcoidosis is the appearance are quite suggestive of either sarcoidosis or even TB, but sarcoidosis is my top differential here because of the perilymphatic distribution of the nodularity. This
Great. So he's 32. Then he started losing some weight as well. And they decided to go for a PET They were worried about a malignancy. I agree with your description and with your differentials. I scroll through the PET.
Yeah, it's got quite FTE with areas of uptake in the lymphatics, but in the lungs as well as bones as well, especially spinal processes.
Yes.
So
it was thought that this patient had a diffuse malignancy. So what they did was he had an EBUS to sample the mediastinal lymph nodes. And on EBUS, there were non-caseating granulomas. Rather than non-caseating, yes.
So non-caseating granulomas are more indicative of sarcoidosis rather than...
Exactly, yes.
So sarcoidosis can involve any system of the body, including as well.
Including
so it's more fitting with the sarcoidosis, multi-system sarcoidosis.
Multi-system sarcoidosis, that's...
So patients would need the level ACE level and other referring to respiratory and rheumatology as well.
Great. Hold on. I'm just referring back to the presentation, which I will share with you now. Okay, so don't forget sarcoidosis is a great mimicker. And this patient's PET scan was reported as a stage 4 malignancy, actually. And then the EBUS clinched the diagnosis that this was sarcoidosis, not malignancy. So it's a multi-system condition, as you rightly said. Pulmonary and mediastinal involvement occurs in 90%, but this case was quite unusual because of the skeletal manifestations as well. And the bony foci can be FDG avid on PET. So symmetric hilar and mediastinal lymphadenopathy is seen in more than 75% of patients. And then you can get some pulmonary parenchymal changes as well because of perilymphatic micronodules, which are seen. So you see the fissures being sort of dotted with lots of nodules. Airspace opacities or consolidation and alveolar sarcoidosis. It's a bit less common, but we saw it in this case as well. Lung masses are less common. End-stage sarcoidosis, stage 4, would lead to pulmonary fibrosis. And sometimes you can get pleural effusions as well, usually small or moderate in size, and they usually resolve within a couple of months. The differential diagnosis in sarcoid depends on the stage. So in stage 1, which is when you have intrathoracic nodal enlargement only, so there's no involvement of the lung parenchyma, that would be a differential of intrathoracic nodal enlargement. So things like lymphoma come to mind, especially in a young patient, 32 years of age. In a patient with stage 2 sarcoidosis, as was the case with this gentleman, he had both alveolar and nodal involvement. So again, lymphoma would also be a differential or a diffuse malignancy. With stage 3 sarcoidosis, that involves just the lung parenchyma with no significant intrathoracic lymph node enlargement. And the differential of that would be cryptogenic organizing pneumonia because there's involvement of the lung parenchyma, and also hypersensitivity pneumonitis, which we'll see an example of soon. The differential of interlobular septal thickening, which we didn't see much of here, but it's also a lymphangitic process, would be lymphangitis carcinomatosa, typically in a patient with a known malignancy, with a significant interval increase in size of the primary tumor and infiltration into the vasculature and into the lymphatics. And with stage 4 sarcoid, your differential would be that of a pulmonary fibrosis. So UIP pattern would be a differential, or a fibrotic NSIP picture. Okay?
Yeah.
Next case, 16. This is your history. So it's a 58-year-old male who presented with chest pain, and they're querying aortic dissection. So I'll prepare the images for you. Okay, so focus on the aorta, okay, because we're querying aortic dissection for this patient. Go through. This is a non-contrast CT. And I will window it slightly for you. Just to make the finding a little bit more conspicuous. So focus on the thoracic aorta. And now I will show you. Did anything catch your eye, incidentally?
Yeah, there was a bit hyperdensity, and I think there was a atherosclerotic with mural hyperdensity, basically intramural, and there was slightly proximally there was a focus of calcification. I think atherosclerotic. I was just wondering whether there was a penetrating ulcer there. The adjacent to the spread was a bit stranded, so obviously we'll see in the proper windows, but definitely there is a intramural hyperdensity suggestive of
Okay, great. I wasn't sure it was projecting very well on your end. I'll show you an aortogram now, an arterial phase scan, which confirms your suspicion.
Yeah, there is quite circumscribed mural areas of hyperdensity, not having contrast there. So within the wall is thickened and there's a hematoma there.
For your diagnosis?
Intramural hematoma, acute aortic syndrome, and the fact's a bit stranded, but I don't think it's ruptured there or there's any ruptured plaque.
Oh. So you would window this, isn't it, to look for a flap, a dissection flap?
Yeah.
There was no dissection flap in this case.
So I would refer urgently. I will. Obviously, I will look at the extent of this intramural hematoma, whether, again, it's following the Stanford AOB distribution. But I will alert the on-call vascular surgeons.
Right. Well done. So, let's go back to...
The extent is quite large, distally as well. Quite a long segment.
Okay. So this was aortic intramural hematoma. So on the unenhanced scan, this is the aim of doing an unenhanced scan in a patient presenting with a suspected acute aortic syndrome. It's to outline this crescentic hyperdensity within the wall of the aorta. And then on contrast enhanced CT, there was eccentric aortic wall thickening. There's decreased luminal aortic diameter along the extension. In this case, it was quite extensive, extending down to the abdominal aorta as well. And you were corrected by looking for a penetrating aortic ulcer or anything similar to that. as an outpouching of contrast beyond the aortic margin. And also little ulcer-like projections, which I'll show you an image of from the literature. These outpouching of contrast. So these conditions would all be precursors of aortic dissection. So as you said, it's important to look for the actual dissection flap, which was not present in this case. So this is hemorrhage within the vasa vasorum of the aorta, within the wall of the aorta. It can evolve or coexist with aortic dissection in almost half of cases. Spontaneous resolution can occur in a minority of patients. In almost half of patients, they can get aortic rupture, and rarely it can stabilize over time. But the predictors of a poorer prognosis and of increased mortality are if it's a Stanford A, so if it's involving the ascending aorta, if the aorta is very dilated, so over 4 centimeters for the descending and roughly over 5 centimeters for the ascending aorta. An intramural hematoma thickness of more than 10 millimeters is a poor prognostic factor. And if you see ulcer-like projections suggestive of interruptions of the wall, those are very likely to eventually cause a dissection flap. This is what penetrating atherosclerotic ulcer looks like. So this is a small ulcer with a large intramural hematoma. So that's an example there from the literature, very, very large. So these cannot progress to intramural hematoma and eventually to dissection. Okay. Now if we move on to the next case, case 17. Are you still there? Can you still hear me?
I was reading the history.
Ah, good. So 33-year-old hypertensive male with mild left ventricular hypertrophy on echo. And they were querying a secondary cause for the hypertension. So he was on multiple antihypertensives. And when there's hypertension, which is somewhat resistant to medical therapy, in a young patient, especially, we look for a secondary cause. Okay, I will just load the images for this patient. So this chap had an MRI and focus on the aorta.
So the PowerPoint presentation is on the screen.
Yes, I'm just preparing it. Okay. So this patient had an MRI.
Mm-hmm.
Focus on the aorta, so follow it from its origin, across the arch and down.
Yeah.
Descending thoracic aorta. And I'm going to play the cine images for this patient. Ignore everything else.
Mm-hmm.
And look at the aorta.
Yeah.
And this patient is a young hypertensive, 33 years old. Do you think you have seen an abnormality?
So in the aortic arch post, I think, origin of left subclavian, there is a stenosis, focal stenosis, which is in keeping with the coarctation of aorta. I will check with axial and coronal sequences as well. Patient would need blood pressure measurement in left and right side of the arm and upper and lower extremity distribution as well to check whether there is a discrepancy in the blood pressure. Ideally, I mean, since it's a young patient, that's why I think probably we went for MRI and not for CT angiogram.
Yes, yes.
but this is quite suggestive of a coarctation of aorta, which needs
Okay,
to
great. Well done. There it is.
yeah,
This is an angio, 3D angio post
it's post or distal to
MR, which
left.
demonstrates beautifully. Exactly, yes, which is the typical site, isn't it, for a coarctation. So this patient had stent placement because they tried to angioplasty the stenotic segment, but it failed. So he had to have stent placement. And this is the chest X-ray post-op. Unfortunately, I don't have a pre-op chest X-ray to look for rib notching and the manifestations of coarctation pre-op, but that was great. Well done. I'm aware that you don't see too many CMRs, so that was really good. Okay, so coarctation of the aorta, you would see the classic figure of 3 morphology on chest X-ray. And the aortic stenotic segment typically occurs just distal to the origin of the left subclavian artery, as you outlined. So most of them are postductal. And you do get a little bit of pre-stenotic dilatation and then post-stenotic dilatation within the descending thoracic aorta because of some holdup at that stenotic segment. And you're usually able to see inferior rib notching in ribs 3 to 8. Ribs 1 and 2 have a separate supply. The intercostal vessels there have a separate supply. So that's why you don't see inferior rib notching in those ribs. So cardiac MR allows morphological and functional assessments. You can calculate the pressure gradient across the stenotic site. You can evaluate for a bicuspid aortic valve, which is an association in 50 to 80% of patients. So a substantial amount of patients also have bicuspid aortic valve. And the treatment first line is balloon angioplasty for older children and adults, or for patients with recoarctation. And stent placement is indicated, as in this case, for patients who have recoarctation or after a failed angioplasty, as happened with this gentleman. Okay. Let's go for case 18 now. So this is the history. It's a 77-year-old lady who presented with hemoptysis. Quite a few patients in my presentation actually presented with hemoptysis. So let's load up her imaging. Okay, can you see her chest X-ray?
Yeah.
Yes.
It's a frontal chest radiograph of a skeletal immature patient, which is demonstrating bilateral patchy consolidation throughout diffuse consolidation throughout both lungs, sparing just the right lung apex. Obviously, it's an AP erect, so heart size cannot be accurately assessed, but it grossly looks enlarged to me. There's no pleural effusion though. So differential, there's no retrocardiac opacity. The bones appear normal otherwise on this projection. And there's no hilar enlargement to me, and hilar in the normal place. There's no hypovolemia of the lung. So considering these findings and the presentation of the patient, I mean, these could represent in the context of hemoptysis infection, infection patient would need to, I would need clinical history where the patient is septic. If the patient is septic, then this could represent infection. If the patient is not septic, then alveolar hemorrhages can present, bilateral alveolar hemorrhages can present these kind of picture. From gross lung infarction and bilateral lung infarcts can give you this kind of presentation with hemoptysis. So these are my differential.
So with lung infarcts, would you expect that peripheral sparing?
Yeah.
See that there's peripheral sparing here. Yeah. So that would be quite unusual for pulmonary infarction. This is quite central, isn't it?
Yeah.
Okay, so I'll show you her CT. Oh, there's a CT just with contrast for her. So I'll have a scroll through, have a look, and look at the lung parenchyma and see whether this confirms or whether it points to a particular diagnosis. Your differential was correct.
So there's definite subpleural sparing of the lung parenchyma, and there's a bilateral pulmonary, I think, consolidation with the air bronchograms as well. More perihilar distribution.
That's central, isn't it?
Both lobes. Sorry?
Quite symmetrical, isn't it?
Yeah, they are quite symmetrical. Pulmonary alveolar proteinosis can sometimes give this appearance as well.
The periphery.
It can spare the subpleural spaces.
Yes, usually not.
Yeah.
Usually diffusely homogeneous.
I'm just wondering, pulmonary edema can, but again, it's quite atypical of pulmonary edema.
And there are no effusions.
Yeah, there's no effusion, and
the heart size is normal for an elderly lady.
It looks like a more consolidative picture to me.
Yes. This was pulmonary hemorrhage.
Hemorrhage, okay, again. Okay.
Yes, she presented with hemoptysis.
So vascular, is the underlying vascular
not that we know of, but that's a very good point because we need to rule out any underlying vasculitic processes. I will revert back to the presentation. So this was pulmonary hemorrhage. So bilateral airspace disease in a patient with hemoptysis. The lower lobes could be more commonly affected sometimes, but this is maybe also diffuse, as in this case. The chest X-ray was very, very non-specific, just multifocal airspace disease, roughly symmetrical. The HRCT was also not very specific, multifocal bilateral ground glass, centrilobular, geographic and diffuse with consolidations as well. She could develop subpleural reticulation and honeycombing if there is recurrent hemorrhage into the lung. And HRCT is the imaging modality of choice. As you correctly said, the differential diagnosis would include pulmonary edema, but you would look for other features to suggest this, such as cardiomegaly, bilateral pleural effusions, and bilateral reticular opacities or airspace disease. And there were none of these in this case. Pneumonia, multifocal consolidation. She did not have any infective symptoms at all. And now she's being worked up for to exclude these conditions. So granulomatosis with polyangiitis, so Wegener's, good posture syndrome, and they would check for typically anti-basement membrane antibodies. ARDS can also be one of the differentials, but the pattern is not typical. And Schweck-Strauss syndrome, which is a systemic vasculitis with peripheral eosinophilia in a patient with asthma. So those would be your differentials for that appearance. And you don't really need to get to one diagnosis. It's just important that you outline to the examiner that you're thinking logically, and you're saying, if there is cardiomegaly and pleural effusions, I would think of paredema. If the patient is septic, I would think of multifocal pneumonia and all of that systematically. So you show him your way of thinking, your way of thinking and your thoughts, and you're vocalizing your thoughts, and at the same time you're showing your knowledge as well. Okay, so this will be your last case now, case 19, and this is your history. 75-year-old lady with increased work of breathing. So I will prepare the DICOM for you, for her. Okay, can you see the chest X-ray?
Yeah.
Okay.
It's a frontal chest radiograph of a 75-year-old lady with increased work of breathing, which is demonstrating bilateral low zones, reticulonodular shadows. More predominant on the right side, involving the costophrenic angles as well. I cannot see any pleural effusion. Heart size appears normal. Rest of the lung appears normal as well. The bones appear unremarkable on this chest X-ray, and the hilas are not enlarged. The normal AP window is preserved. The findings are quite suspicious of, in the context of history of pulmonary fibrosis, although I cannot see much lung volume loss on either side. 1, 2, 3, 4. Yeah, so ribs are up to 7. So I cannot see much volume, hypovolemia of the lung, but in the context of history,
which is typical, isn't it?
Yeah, I would consider HRCT to further evaluate the pattern, but here my initial suspicion is pulmonary fibrosis. I will also compare with the previous chest X-ray if there's any, to see whether there's a rapid change or it's an ongoing process which is getting worse.
This was her first chest X-ray. So we did an HRCT chest, as you said, to further evaluate the findings. So I will scroll through it in lung windows, and then I will scroll through it in mediastinal windows, because there's an important finding there. Okay. All right, so we'll start with the lung windows. Okay.
Yeah.
And now I'll go to the mediastinal windows and have a look at the mediastinum. See if anything catches your eye there.
Yeah. So on lung window, there are bilateral bilateral lower lobes with I would say honeycombing pattern. Yeah, honeycombing and including the mainly with the epicophyseal gradient, and there's probably some suggestion of secondary bronchial dilatation, especially in the medial aspect. However, I can see on the mediastinal window the esophagus is dilated.
Well done.
And in the context of combining both these findings, what do you call it, systemic sclerosis with...
yes.
So I would check for other symptoms of systemic sclerosis and CREST syndrome as well, whether this patient have got CREST syndrome. But the findings here are fibrosis as part of the systemic sclerosis and esophageal dilatation.
Well done. Well done. So that's the key. So they will often do this in the exam. At least that was my experience when I had done it. They might give you something which is fairly common, such as a lower lobe fibrosis, and then you need to have a look around to make sure it is not a lower lobe fibrosis secondary to another underlying condition, as happened in this case. So let's go back to the PowerPoint. So idiopathic pulmonary fibrosis is a diagnosis of exclusion, actually. You can see a UIP pattern in several other conditions, such as with rheumatoid arthritis is the commonest pattern, with systemic sclerosis or CREST syndrome, as you rightly said. Look for evidence of asbestosis, pleural plaques, pleural thickening. If the patient is a cardiac patient on amiodarone, or he's on immunosuppressive therapy, methotrexate in particular, these can also give a lower lobe fibrotic picture. It would be a drug-induced lower lobe fibrosis. And also if there is a history of known NSIP or DIP, discoimative interstitial pneumonitis, which happens in smokers, or chronic hypersensitivity pneumonitis. These can also develop lower lobe fibrosis as end stage. So UIP, this is a bit of a more kind of end stage chest X-ray, because there is extreme volume loss, there's lower lobe reticulation. On the CT, there is extensive traction bronchiectasis, reticulation, and honeycombing as well. So often there are these multiple rows of subpleural cysts, which are termed honeycombing. Traction bronchiectasis and interlobular septal thickening, the three features, are suggestive of a UIP pattern. So the distribution, as we saw before, these type of patients have a vasopredominant findings, an apicobasal gradient, subpleural predominant, they're often heterogeneous, and the features are honeycombing, reticulation with peripheral bronchiectasis, and the absence of these features would suggest an alternative diagnosis. For example, as we saw before, if there is the predominant pattern is ground glass, then that would favor an NSIP picture rather than a UIP. And this is a chest X-ray of another patient with extensive bilateral pleural plaques, subdiaphragmatic as well. So he had asbestosis. So look for all these findings, because these would be important negatives. You can say things like, I cannot see evidence of calcified pleural plaques, which would suggest an asbestosis. I can see a dilated esophagus with an air fluid level, which would point to this being part of scleroderma, just so that you can show the examiner your thought process.
Thank you.
Okay, you're welcome. Let's go to candidate 6 now. So, can you hear me?
Hi.
Yes, hi. Are you ready?
Yep.
Okay, so this is your history. It's cough and shortness of breath in a 50-year-old lady who had previous breast surgery. So we'll prepare your images and I will share the screen in a bit.
Yep.
So we'll start with the chest x-ray and then we'll move on to the CT. I'll window it for you because it doesn't project very well. Just talk through it, even if you don't see anything.
Yep.
I'll show you a CT in a bit, so don't worry too much.
So this is a frontal chest radiograph of an adult female patient. I know that she's had previous breast surgery, but I don't see significant asymmetry in the breast. I'll look for surgical clips in the axilla, which I can't see very clearly either. Looking at the chest itself, the lung and the mediastinum, I'm just getting very blurred images, unfortunately, on my end. It's going on and off in terms of reticular patterns. I think there are fairly prominent upper lobe reticulation, I think. And I see some possible surgical clips on the left side projected over the mid-zone.
Perfect. Those were the breast surgery clips. She had a wide local excision.
Okay. So I think there's slightly more prominent reticulation in the left side. I can't see the right very clearly, but I think similar. And the heart size is unremarkable. I don't think it's enlarged. So to take this case further forward, I'd like to find out if there's previous radiographs and if there's radiation or not, and proceed to a CT.
Good. Apologies for the quality. That wasn't the best, but she has quite a nice CT, which I wanted to show you.
Yeah, no, it's, I think the image is on my side actually, so the connection on my side is quite bad.
Oh, okay. Can you see the CT now?
Maybe yes.
Okay, I'm going to go start scrolling through it. Focus on the lungs. Okay. And she's 50.
Okay. So these are axial CT images of this patient's chest. I think this is HRCT, no contrast has been given, I believe.
Yes.
There are florid reticulations in the upper zones bilaterally and in the base as well, actually. There's some areas of nodularity as well. I don't see any significant traction bronchiectasis. Going more superiorly in the apices, so I don't see any. I was trying to look for any mosaic attenuation, but I think there's some more in the bases.
That's correct. Well done.
And I think putting these together with regard to some minor nodularity and the reticulation together with the mosaic attenuation, I wonder if this patient has some form of pneumonitis. If it's lower zone and more nodular, I think it might be acute hypersensitivity pneumonitis. But there's a lot of fibrosis as well, so it could be a long-standing thing.
Yes, that's exactly right. So this is the head cheese sign, actually, for chronic hypersensitivity pneumonitis. So we've got three densities here. You've got ground glass, you've got normal lung, and you have these areas of air trapping. So there's a mosaic attenuation pattern, and there's these three densities.
Okay.
Well done. So in this case, her breast surgery history was a red herring, really. It wasn't really relevant to the case as such. Let's go back to the PowerPoint. Okay, so this was chronic hypersensitivity pneumonitis. Chest X-ray, very, very non-specific. Small opacities may spare the apices, as in this case. Sometimes spares the bases, not in this case. There's reticulation, there's airspace opacities. And then on the CT, we could see homogeneous ground glass opacity, usually bilateral and symmetric, centrilobular nodules, as you said, and hypoattenuation and hypovascularity of scattered secondary lobules, giving a mosaic attenuation pattern. And these three densities make up the head cheese sign, which is quite specific for hypersensitivity pneumonitis. And this is what head cheese looks like in real life, and that's where the name comes from. This pattern can be seen in other infiltrative and obstructive processes. There is some mention in the literature of this pattern being seen in sarcoidosis, but sarcoids can look like anything really. And also atypical infections associated with bronchiolitis, like mycoplasma pneumonia, for example. Okay, great. Okay, so I'm going to scroll through this. I've altered the window slightly, just so that it will outline the findings a little bit more.
Yep.
And whenever you're ready, just have a look. I'll scroll through once again. And whenever you're ready.
So these are Excel CT slices of this patient's chest. This is a CTPA. It's windowed adequately to show that the bilateral pulmonary emboli. I don't think I saw any saddle embolus in the MPA. I think that's the main diagnosis. I'll look through this on lung windows as well to look for any abnormalities. Those are filling defects, and the most likely thing would be a pulmonary emboli.
Good. Any other features you would look for?
So sometimes you can see wedge-shaped infarcts in the lungs, and you can also look for right heart strain.
What do you think in this case?
So there's some bowing of the interventricular septum to the left. I didn't see any reflux into the IVC or the intrahepatic IVC rather, but that would be sufficient. There is some, apologies. So this will be keeping a right heart strain as well.
Yes, great. Well done. So let's go back to the presentation. Okay, so this was a case of bilateral pulmonary emboli with right-sided heart strain. There was an abnormal position and flattening of the interventricular septum, so it was bowed to the left side. Right-sided ventricular enlargement, pulmonary trunk enlargement, it's bigger than the aorta. And there are features of right-sided heart failure, such as contrast reflux into the IVC, the dilated hepatic veins, and also sometimes you can see a dilated azygos venous system. This is another patient, but it depicts the findings of right-sided heart strain. So we've got a bowed interventricular septum, a right ventricular to left ventricular ratio, which is more than 1. And these patients have higher mortality than patients without a right-sided heart strain pattern. Okay, good. As you said, you would look at the lungs as well on lung window to look for any pulmonary infarcts. Good. On to the next case now. Case 22. That's the history for you.
Yep.
34-year-old male who was brought to the hospital after being stabbed in the chest. So let's have a look at the imaging for this gentleman. So a CT was done. And I will show you 2 windows. I'll show you the soft tissue window, and then I'll show you also the lung window. Okay? So just have a look. Okay, I'll switch the window for you. Do
Okay.
you want to see the soft window again, or?
Yeah, that'd be great. But I think there is the stab wound. The patient does the axial slices both in soft tissue and lung windows of this 34-year-old chap who is coming with a stab wound. The soft tissue window demonstrates the entry point of the stab, which is just to the right of the sternum, evidenced by airlock used subcutaneously and also within the tissue just above the pleural space. And I think I saw some likely pulmonary hemorrhage within the lung as well. And there's associated pleural or rather hemothorax inferiorly and a small anterior pneumothorax as well. I'll be concerned about injuries to either the large vessels, specifically the aortic arch, and the heart itself. I'll look for any pericardial effusion in the soft tissue window, and look for any other. Actually, I thought I saw a small pneumothorax on the right as well, but sorry, on the left. But I think it's probably just a subpleural bleb or something. I don't see any obvious tracheal injury, but I can't exclude a bronchial injury in the mid section of the CT itself. However, this is a major injury, and I'll be suspicious of any injury to the hilar as well. So I would advise the clinical team of my findings. I'd also like to ask the team how the patient is doing. Is he stable or not at the moment?
Good. And this is a contrast study. So you can look for active contrast extravasation into this area,
Okay, yeah.
which would signify that there is active bleeding in this area. It is not present in the scan.
Okay.
We'll just bring out the soft tissue window again. So this patient had a pulmonary laceration. Okay. It's a severe injury, but fortunately, the right internal mammary, the subclavian, and the great vessels of the thorax were not injured. But it's in that area, very, very close to the internal mammary artery on the right side. As you said, there's a small right hydropneumothorax, but there was no active contrast extravasation. So these were areas of lung contusion, and there's disruption of the lung architecture because of the laceration, of course. But there's no active bleeding into the area, so there's nothing to embolize really at the moment.
Okay.
And sometimes these patients can develop post-contusion pneumonia with some cavitation in the region where there was previous hemorrhage. Several days after trauma, this can develop as well. So that would be an important complication, post-contusion cavitation and pneumonia. So then patients can get septic because these cavities can get infected. So they become septic over the subsequent days. Good. And the last case for you, case 23. All right, so the history is 51-year-old male who presented with chest tightness.
51-year-old male chest tightness.
Chest tightness, yes. I'll show you his CT on lung window. It's a non-contrast CT. I will show you that again because I think it jumped a bit in the beginning. Do you see any abnormality in the lungs?
I think bilaterally there are centrilobular airspace densities, not nodules, but almost like ground glass appearances. I don't see anything else, to be honest.
So what other additional features would you look for?
I don't see pleural
There are
effusion.
no pleural effusion.
I mean, I'll look at on soft tissue windows, but I don't think there's any obvious lymphadenopathy. I don't see any volume loss or lung collapse. I think with this is a very florid picture bilaterally, so it's probably something which is affecting the whole lung. Somehow inflammatory process, possibly a pneumonitis again. Hello.
Please bear with us. I think Alexia got disconnected. So just please hold on.
Yep.
Hello? Okay. Sorry, my connection became unstable for a second. Okay. So, yes. So this was a patient with subacute hypersensitivity pneumonitis. So this is characterized by a very diffuse bronchiolar picture. There's centrilobular ground glass nodules, and sometimes you can see air trapping. Usually it's diffuse, as in this case, and random, but it may be also upper and mid-lung zone predominant. So the differential would be any inflammatory process occurring at the level of the bronchi. So an acute interstitial pneumonia, respiratory bronchiolitis in a patient with specific pneumonia. There's usually some more prominent sarcoidosis, alveolar sarcoidosis in this case, because it's a process centered the center of the pulmonary. Okay. Candidate 7 now. Last candidate for the Okay, sorry about that. Let's see. Can you see my screen?
Hello, yes, I can.
Hello, you're candidate 7, right?
Yes.
Perfect. Okay, so you have the last few cases of the day. So we'll start with this one. She's an 80-year-old lady who's in theatre recovery after having a right common femoral endarterectomy. And suddenly she developed a low blood pressure, oxygen saturations of 88%. So the clinicians were worried about a PE in this lady. Okay, so I'm just preparing the images for you. Okay, can you see the CT now?
Yes, I can.
Great, okay. So I'm just going to scroll through
So it's
on soft tissue window, and then I will scroll again on lung window.
all right. So it's pulmonary angiogram.
Actually, it wasn't done as a CTPA. In fact, there is a specification of both the aorta and the pulmonary trunk and the pulmonary vasculature. So it was almost done as a kind of a triple rule-out scan. I will change the window to the lung window, and I will scroll through that again.
So I can see bilateral posterior and basal consolidation patches. They are more dense on the. They are fairly symmetrical, maybe more extensive on the right side.
I'm going to scroll.
Surrounded by ground glass densities.
She's just had surgery. She's in theatre recovery.
Yeah, the history is not in keeping with PE. This is not the time of pulmonary embolism.
Also, if your window accordingly, there was no PE. I agree.
Yes. So this is very short or immediate post-operative sequelae, right?
Yes. She's still in recovery.
Yeah.
And she has a low blood pressure in hypovolemic shock.
Yeah. So maybe there is a complication in the femoral region, and maybe probably here pulmonary hemorrhage, maybe due to anticoagulation.
Yeah, she did.
Sorry?
This is what we were talking before about the kind of the gradient that there's ground glass
Yes.
in the midline, and then it becomes more consolidative in the dependent regions. Does that
ARDS.
Yes. So this is non-pulmonary cause of ARDS, an extrapulmonary cause. In this case, it was hypovolemic shock. So it's lung damage resulting in this leakage of fluid into the alveoli and the interstitium, leading to non-cardiogenic pulmonary edema.
Yes.
Well done. So let's go to the presentation. ARDS. The causes can be pulmonary or extrapulmonary, as in this case, hypovolemic shock. So we went through this description earlier. So in the early phase, you have this pulmonary opacification, which demonstrates this AP gradient, density gradient within the lung. So more consolidative in the dependent regions and more ground glass predominant. And the lung apices and the upper zones are relatively spared. And then late phase, complete resolution in some cases, but in the majority, they would develop areas of reticular and ground glass opacification, sometimes fibrosis, and pulmonary cysts of varying size. Okay, good. So let's go to the next case. There's the history for you. A 19-year-old male who's involved in an MVA. So another trauma case. And we did a CT. So I've selected the relevant images and have a look on lung window.
Okay, I'm still looking at the PowerPoint.
Yes, I'm sharing it now. Okay.
Yes. Okay, so I assume this is contrast enhanced CT of the chest.
Yes.
I can see
Yes.
bilateral multifocal consolidation patches as well as ground glass opacities, more on the left basal segments, as well as small pneumothorax, left-sided.
Yes.
There are small cystic areas posterior to the heart and maybe lateral to the descending aorta.
Mm-hmm. Any idea what those are called?
Sorry, there was a motorcycle passing. I didn't hear the last word.
Sorry, I didn't catch that.
Sorry, it's a pneumatocele.
Yes, post-traumatic pneumatoceles. That's right. These cystic spaces represent post-traumatic pneumatoceles. There are, as you said, there's extensive contusions and consolidations bilaterally. If you window it, there's no active hemorrhage into this region. But as you said, the predominant lobe involved by this injury, this chest trauma, is the left lower lobe. And there was a small left pneumothorax in the apex. So well done. You just need to keep looking. Looking for more with these trauma scans.
And this is pectus excavatum, right?
And yes, well done. Significant pectus excavatum. Great. Okay, so case 26. I will give you the history. So it's a 39-year-old man who presented with dysphagia.
Okay, so this is a frontal chest radiograph of an adult male patient showing long, linear, well-defined opacity on the right side of the mediastinum, extending below the hemidiaphragm and up to the neck. This pattern is in keeping with dilated esophagus given the complaint of the patient. So I think we are dealing with a case of achalasia. Next step would be performing a upper GI fluoroscopic study or a CT scan.
They would still need an upper GI direct visualization. Of course, to
exclude masses.
To manage it. Yes, it is massive. Okay, great. So this was a case of achalasia. There is a dilated esophagus containing the extensive residual food which has been accumulating slowly within it. And this happens because of failure of organized esophageal peristalsis. So the lower esophageal sphincter doesn't relax adequately. It can be primary or secondary to another cause, such as a malignant tumor. And the difference between these clinically is that these patients present with dysphagia for both solids and liquids, whereas patients with an esophageal carcinoma present with dysphagia for solids only, usually. And the treatment is pneumatic dilatation, and then it's surgical biomyotomy. Okay, and the key on the chest X-ray was that kind of very granular appearance of that food debris lying within a dilated viscus within the mediastinum. Good. This is the last case now, case 27. So this is your history. 17-year-old lady with chest wall pain, previously well, previously healthy, no admissions to hospital.
Okay, I can still see the PowerPoint presentation.
I'm preparing. Okay, so we'll start with chest X-ray. Can you see it now?
Yes. So
Okay.
this is
Whenever you're ready, have a look. And whenever you're ready.
so this is a frontal chest radiograph of a 17-year-old patient, as well as upper abdominal radiograph. I can see the right lower zonal abnormality in the form of well-defined opacity. Has an the upper margin is curvy linear, almost well-defined, except for its medial end. It's not silhouetting the right heart border, but it is silhouetting the right hemidiaphragm. I would like to window a little bit to make sure if I can see the copula of the diaphragm through this opacity or not.
Sure. It's not changing too much. I can tell you that the right hemidiaphragm is obscured.
Oh, all right. So, in absence of trauma, I would exclude diaphragmatic eventration. I cannot see any evidence of right apical masses to suggest diaphragmatic paralysis. Maybe a fluoroscopic study help with excluding this.
Septic.
It's a right lower pneumonia, given the pleuritic pain.
And the fact that she's septic.
Sorry?
And the fact that she's septic. And she has this pain.
Oh, I did not know she's septic. I thought it's just pain.
No, I told you she's septic after that, yes. So she presented initially with chest wall pain, and eventually she became septic.
Okay, so this is right lower consolidation, mostly pneumonia, given the history.
Mm-hmm.
I'd like to correlate, of course, with the inflammatory markers and the clinical picture, as you said. A lateral X-ray would help localize the pathology.
Or else?
An ultrasound also would assess for associated pleural effusion.
Yes, but we know that there is an effusion, isn't it? Because the right hemidiaphragm is obscured.
Yes.
Okay, so right lower zone pneumonia with an effusion, possibly a paranpneumonic effusion.
Yes.
Yes, yes. So that was the initial presumed diagnosis. She was started on antibiotics. She was not getting better. She became increasingly septic, and a CT chest, abdomen, and pelvis was done to try and identify whether there's anything else.
Yes, so in this scenario,
One alternative diagnosis. So I'm going to show you the lung window.
so
And I will show you the soft tissue window, and then you can tell me about.
I can see early or mild 3 in bud appearance, maybe in the segments abutting the density that I cannot really appreciate its details on this window.
Okay, I will. That's good. I will change to the center window. Have a look.
Right. I can see abnormal paraspinal, as well as posterior basal pleural split pleural sign with enhancing wall. So this is a complication of the pneumonia. It's an empyema. This needs urgent drainage via chest drain or a pigtail insertion. I think this also might be complicated by a paraspinal extension of this pyogenic process.
Well done. There's a paravertebral collection, isn't there?
Yes.
Now on bone window, have a look at the area around the spine.
It's extending on both sides of the spine as well as a large paraspinal abscess.
Mm-hmm.
And there is ill-defined irregular erosion of the right side of the lower dorsal vertebrae. So it's completed by spondylodiscitis.
Yes.
This is an emergency, of course, and I would like to inform the neurosurgeons as well as the cardiothoracic surgeons.
Can you think of an organism which likes to do this? Particular organism?
Staph aureus?
TB.
TB, okay.
TB. Paraspinal abscess, empyema, and bone erosion.
Mm-hmm.
Great. She did very well. This lady did very well. Her MRI showed a discitis. She's done very well subsequent to that. It's well done. You would need to recommend an MRI, definitely.
Yes.
In this case. So the final diagnosis was empyema and paraspinal abscess in a patient with TB. There was a peripherally enhancing large paravertebral fluid density collection with bone erosion of the adjacent thoracic vertebral bodies. There was a large loculated pleural effusion surrounded by enhancing thickened pleura, the split pleura sign, which you rightly mentioned. I didn't show you these, but there were enlarged right hilar and subcarinal lymph nodes as well. And you outlined this very well, almost immediately, the perihilar tree-embodied nodularity within the middle and right lower lobes as well. So the differential diagnosis would include malignant pleural effusion, malignant mesothelioma, of course, because of that irregularity of the pleura. Iatrogenic pleural loculation in cases with pleurodesis, for example, or abdominal causes. Sometimes a pancreatic pseudocyst can erode through the diaphragm and it reaches the pleural space and can have a similar appearance. But it would be very unusual for a pancreatic pseudocyst to do this, but it's possible. So you can include it as a differential diagnosis. So well done.
Thank you very much.
So this is a loculated pleural effusion with intrinsic air collections. This is another patient. And there's enhancement of the left pleura. So this is an empyema And in the absence of intervention, this would be diagnostic of a bronchopleural fistula, which means that there is a connection between the bronchial tree and the pleural space. And that's where these locules of gas would come from. So just be on the lookout for those. Okay, that's it for today. Well done to all the candidates, and thank you for putting yourself forward. And thank you everyone for joining us today. I hope it's been helpful. I wish you the best